surgical techniques.
Typical technique we have for the management of these patients. If I could have my slides. I have no financial interest. Just a little bit of a comment on cultured limbal epithelial transplant, or CLET, and simple limbal epithelial transplant, SLET, these two newer procedures. As you can see, the variety of, the publications really deal with more autograft than allograft. Some 80% of all CLET that's been published are autografts, and 90% of all SLET procedures. And really, unfortunately, when reporting these procedures, they lump the autograft outcomes with the allograft. In addition, if you look at short-term success, the procedures do pretty well, although the CLET and SLET don't do well as the traditional procedures, and we have no long-term data on those two procedures, and we do on our standard procedures. So we certainly are interested in those procedures, but at this time, they certainly don't stand up to our traditional procedures. So I'd like to review the different transplant techniques we have, first for unilateral and then bilateral disease. I won't spend a lot of time on autografts. This was first published by Kenyon and Sang back in 1989. It's certainly the procedure of choice for unilateral disease, and we have great outcomes. The biggest challenge is convincing the patient to operate on the fellow eye. But we certainly have data knowing that the fellow eye does not have certainly high risk. And looking back at all of our autograft procedures performed in the last 10 years, all donor eyes had a stable surface, and we have no problems if that eye was preoperatively normal. What I'd like to concentrate on, and this is an example of a conjunctival limbal autograft done back in 1990 with the stable ocular surface. What I'd like to concentrate on today, though, is the treatment for bilateral disease, really our challenge that we have. And we can look at keratolimmal allograft, or the cadaver donor procedure, and living-related conjunctival limbal allograft, and then a combination of these two for the most severe cases. So the advantages of a KL-AL, it's one procedure, so you don't need an extra donor. We don't have to find that right donor. And we get a large amount of stem cells. In fact, the procedure we use actually two donor corneas from the same eye. Disadvantage is that we really don't have the tissue typing available in these corneas for most cases. We think there's increased risk of rejection compared to a matched living-related donor. And unfortunately, we don't get conjunctiva with this condition. And so in those cases that Dr. Sipsakis was showing with the severe conjunctival disease, this really isn't an option. But we do have great results in the right patients, and these are two patients who had severe chemical injuries. You can see the second slides, the ocular surface and the KL-AL tissue after so many months, and then finally subsequent penetrating keratoplasty for visual recovery. This is one case I'd like to highlight, a patient with congenital aniridia. You can see total ocular surface failure with neovascularization and conjunctivalization. The patient underwent a keratolimmal allograft and artificial iris surgery by my partner, Mike Snyder. And here he is with his resumed 20/80 vision, which is best vision that he had prior to his ocular surface disease, 8 years post-op, and he's obtained a limited driver's license. We do get the question, can these cells last a long time? And we have some cases out. In fact, we have over 50 eyes with now 10-year follow-up with success. This is one young woman with a variant aniridia. So you can see her iris looks fairly normal, but she had total limbal deficiency. She ended up with bilateral keratolimmal allografts. She's 12 years out. She's had 2 children. She has 20/25 and 20/40 vision and off immunosuppression. But a procedure we actually are doing more of now than we did originally, and that's living-related conjunctival limbal allograft. The advantage to this technique is we get conjunctiva in addition to limbal stem cells. We can HLA match the donors and potentially get excellent matches, which reduces rejection. We need the donor to have no severe or significant ocular history, so no long-term contact lens wear, no previous history of conjunctival surgery. Now, the disadvantage is that you have to find the right donor and obviously convince the donor. We don't think there's a risk to the donor, but that's a long discussion with the patient. And if you use it as a sole procedure, you're only really addressing 2 quadrants of disease, not 4 quadrants. This is a patient that had long-term contact lens wear, and you can see, as Enrique has showed you, the fluorescein staining over time. Both eyes end up getting total ocular surface limbal failure, and you can see the late staining involves in the visual axis and profound visual loss. She had 9 siblings. 2 of the siblings were identical HLA matches, so she underwent a living-related conjunctival limbal allograft from her siblings. She's now 10 years out, 20/20 vision of both eyes, off systemic immunosuppression. We do also combine these 2 procedures in what's called the Cincinnati procedure. We use living-related tissue and keratolimbo allograft tissue, and I give my friend Jose Gueldi, he named this procedure because he got tired of saying the combination living-related and keratolimbo allograft, so we do refer to it as the Cincinnati procedure. And what this does, in the most severe cases in which there's extensive conjunctival disease, we use a living-related tissue to give us goblet cells and good conjunctival tissue, and then we use the keratolimbo tissue to fill in the gaps between the 2 tissue, and we think this brings a high success in the most challenging cases. So we are showing now the harvesting of the conjunctiva and limbus from the relative, and you can see at the superior, we can take a very large piece of conjunctiva, and I think in these eyes, it's the conjunctival tissue that we harvest is probably equally as important as the limbal tissue, because these patients have very severe conjunctival deficiency. We're now going to recess the scarring here, and in a lot of these eyes, we don't want to resect any of this tissue. A lot of that scar tissue will recess back and form the kind of the palpebral surface. We'll then glue on after a suture fixation of the 2 living-related pieces, and then we'll put the keratolimbo tissue at 3 and 9 o'clock, thus avoiding those kind of gap areas in which we saw conjunctival invasion. And again, for the most severe cases, we think this procedure is the best than either one of these procedures alone. This is another patient who had a severe chemical injury, had 4 previous penetrating keratoplasties, and as you can imagine, with severe conjunctival limbal disease, penetrating keratoplasty alone will not work. So again, we're doing a careful recession of the conjunctiva, not resecting it, and we're freeing up the limbal area, and we can see the failed graft underneath that. This is the living-related tissue at 6 and 12, and then we fill in the gaps with 1 donor cornea cut in half at 3 and 9. Once the surface is stable, then we can go on to either a penetrating or a Dowk procedure, depending on the status of the endothelium. This is this gentleman. We have his slit lamp photo. He's now, again, over 10 years out with good visual recovery. We have published our outcomes, and again, one of the questions is, can you obtain successful ocular surface stability? And depending on the preoperative diagnosis, starting with contact lens disease first, they have the best prognosis because their conjunctiva is normal, they're contact lens wearers. Moving on to aniridia second, and then finally, the worst prognostic cases are the ones with Stevens-Johnson or pemphigoid because of the severe conjunctival disease. But we can have good outcomes with these patients. And this is a gentleman with a severe Roman candle injury. You can see photos at 2 years out and now here at 8 years out with 20/30 vision in the Cincinnati procedure. And then finally, a patient who had our first keratolimbo allograft that we did at CEI. He's 16 years out. You can see the keratolimbo tissue has kind of faded a little bit. He's had a subsequent penetrating keratoplasty in 20/40 vision at 16 years. So I think it's important to have a treatment paradigm. You'll hear more about this from the other speakers, but I think ocular surface transplantation done with a good team approach can have a good success rate. Thank you.
Grazie. Bene. Posto